Well, hello, Karen.
Hello, Richard. Good afternoon. Happy
Good
Monday.
afternoon. Good afternoon and happy Monday to you. It's so lovely for you to join us today. Thanks to your team right off the bat for making this happen. Thanks to Spencer and others who were really, instrumental in getting you and I together today. So I always love it when as they say, love it when a plan comes together. So thank you for that.
You're welcome, and I'll be sure to let them know.
Yeah, absolutely. So, folks, we are joined by Karen Sussman Horgan from VAL Health. And I'm very fascinated at what you're doing at VAL Health. I think probably because I have a public health background before I started doing some of the things I'm doing. You've done some really exciting work in the healthcare space. So I always love it when I get to talk to another healthcare innovator. So this is very exciting. I would love to just start things off, Karen, with just you having an opportunity to say hello. Tell us a little bit about yourself. Maybe tell us a little bit about VAL Health. I want to tease folks, but we're going to talk a lot about it in a minute. And really, I think your expertise in behavioral economics, which is very exciting to me.
Well, Richard, first of all, thank you to you for including me in the fabulous list of women that you have interviewed. I'm honored, and I've learned a lot from those past interviews.
Thanks.
So, as you mentioned, I'm Karen. I co-founded VAL Health 14 years ago.
Nice.
And the intent for that was to bring behavioral science, which we'll get into a lot, but it's understanding that humans are irrational. And how do we use that to create nudges and drive health and healthcare? And I stumbled into this in a roundabout way. My career had been very much on the business side at consulting, boutique consulting firms. I started my career with Bain & Company and got to go live in Asia for a year with them. That was a fabulous experience.
Cool.
And in a roundabout way, my two co-founders, Dr. Kevin Volpe and Dr. David Ash, I'd known them on and off over the years, and they started publishing a lot of research on the impact of how to use behavioral science in creating nudges in healthcare. And we got together, and I liken it like a Reese's peanut butter cup. Chocolate and peanut butter, science and business. And that's how we created VAL Health, to take academic information and bring it to the real world.
When you were in your consulting capacity, and I'm a big fan of Bain & Company, have definitely utilized them in their research and their expertise. Most recently, just a couple of years ago, for some of the work they were doing in generative AI. Is that where your interest and your expertise began in behavioral economics, Karen, or was that prior? You mentioned you had done that for a long time.
It's probably opposite. I had always been interested in health and healthcare and wellness.
Oh, so it's the reverse.
But I started my career more in the technology space, which has actually been very advantageous, because one thing I've learned about healthcare over the past dozen plus years, it moves slow.
Yes.
And people don't ask questions, well, why are we doing it that way? But having come from a technology experience, you ask the questions, you try and break it, you try and move faster. And then with the behavioral economics, I had read the book Nudge by Thaler and Freakonomics. And Kevin and David brought that real expertise. And so that is what really brought everything together.
Nice. And you said that VAL Health has been around for 14 years now.
Yes.
Wow, that's very impressive. That shows some real staying power in a time where healthcare has certainly changed a lot in the last 14 years, not to mention a major pandemic that was smack in the middle of that 14 years. So there was a lot that you came out of that. I was involved a few years back with trying to look at, predictive modeling around healthcare, which is not a new phenomenon. Like, a lot of people are trying to use past behavior to predict future behavior as it pertains to healthcare consumerism and wellness. We were looking at things like consumer patterns, and were the things that you were purchasing kind of indicative of a health state. One of the most famous examples, right, is the woman that goes into Target and starts to buy prenatal vitamins is probably an indicator of either active pregnancy or looking to become pregnant. But then we were kind of double clicking a little bit more into things like, does a person buy motorcycle insurance? If they buy motorcycle insurance, are they likely to own a motorcycle? Yes. Are they likely to potentially be in a more dangerous situation as a result of that? So is that similar to what you're doing at VAL? Is there completely different from consumer behavior versus behavioral economics? I'd love to understand the difference, I guess, Karen.
Fabulous examples you've given.
Yeah.
And I would say so much of what we do in healthcare is learned from the retail and the financial sector, because healthcare is a late adopter of behavioral economics. So behavioral economics, which sometimes is called behavioral science, it is the science that humans are irrational. We have these innate biases that have been, there's like, 100 or so of them that we now understand. You have a bias to the present, you have an aversion to loss and regret, you overweight small probabilities, we're influenced by others. And what we do at VAL Health is we really understand those innate biases that people have, and we harness them. We don't ask you to change them, we embrace them, and we bring that into solutions to nudge health behavior change and engagement. And it may be as simple as changing the default. So, for example, in one of the states, when they expanded Medicaid, they wanted the expansion population to do a health risk assessment. So that way they understood what they were taking on. And they were currently at about 8%. They called us up and they said, how much do we have to pay people to do this health risk assessment? Did our project. And at the end of the day, we said, don't pay them anything. Just change the timing of when you ask the questions. And they went up to over 95% of people completing the health risk assessment by changing the timing, because we made the right path, the preferred path, the easy path for people. And you can imagine they said, we just paid you how much to tell us to do what? And the answer was, yeah, we saved you a lot of money because you'd have to pay incentives. And we thought about the irrationality that people have and how can we harness that to get them to do what is the right thing to do.
Right. And by timing, just to be very clear, Karen, you're just talking about the time of the day that they did it?
No, timing in the enrollment process. So they first they were a big question.
Okay.
So they were asking the question like 2 or 3 weeks. They were doing the health risk assessment 2 or 3 weeks after enrollment.
I see.
And we changed it to be essentially part of enrollment.
Makes sense. Yeah.
And people are so used to the inertia. We played on inertia of I'm answering questions. I'm going through this process. What's a few more questions that I have to answer?
That's a really great real world example. I mean, so much I think in healthcare, we think about, I said friction a second, and I didn't mean to talk over you, but friction is the healthcare workflow, the healthcare process, our healthcare consumption, right, is just wrought with friction all the way through the entire process, right? So I find it very interesting how you said, well, when are you the most engaged? During enrollment, you're the most engaged because you got to get enrolled, right? So yeah, that's very exciting.
Yeah.
When you think about your kind of core mission, I guess, associated, I want to back up a little bit, go a little bigger, a little higher, Karen. Talk to me a little bit about VAL Health's mission and I guess sort of your approach to consulting. There's a lot of, you said this, they were like, how much did we pay you to tell us this?
Right. That's very focused. So our mission is to improve health and healthcare by working through providers, patients, consumers. And we're primarily focused on the US because we have enough issues in this country alone, but we do some international work. And so our mission truly is, how can we help people do things that they know they should do and they have a hard time doing?
Yeah.
And oftentimes we think about, there's behavioral economics for bad. Like gambling really uses behavioral economics to get you addicted. Retail uses it to get you buy more. We want to use it to help you, and you want to go get that mammogram, but you don't do it.
Right.
You want to manage your diabetes, but it's really hard. And so our mission is to help all of that happen.
That's perfect. In terms of the continued, I guess, changed relationship that we see today, Karen, it used to be, there was the relationship between you, the patient, and your provider, and there were certain behaviors that took place there. Yeah. Now we've got this third entity. It's always been there, the health insurer, but it's playing such a much even larger and more complex role where the line between the payer and the provider is sometimes even blurring, right? Especially as providers take on risk and other things. Can you talk a little bit about how behavioral economics has, played a role in that, or I guess maybe even changed as that provider-patient relationship has changed?
So there's a lot to unpack, and I know we don't have all day on this, but if you think of the role that the payer and the provider play. And I'll start probably on not the negative side, but the payer's job is to pay bills.
Right.
And they also, though, are trying to be more of I don't want to say utilization management, but they are trying to do a little bit of care steerage and trying to control a little bit of what the providers are doing. So it's practicing in there. And oftentimes the payers put in, and if you're a payer, I'm not bashing payers here. Oftentimes the payers put in what we call features, not bugs, like such a prior auth or denial. And so there's so much of what can be done between the provider and the payer And how do you reduce denials? How do you reduce the need for prior auths? And I'm not talking about just approving more care. It's oftentimes the payer just doesn't have all the information they need.
Yeah.
And they're putting a burden on the provider.
Right.
So how do you make that right path the easy path to free up the provider's time, get them to be able to give the care to the patient, and free up the payer's time of going back and forth? That's a slightly different answer than where you said, payers and providers are coming together, particularly value-based care and the like.
Sure.
But there's so much that can be done on how do you change framing and how do you change the journey to enhance the experience.
And for VAL Health, when you're thinking about that experience and you're thinking about sort of what a successful experience looks like, what are some of the key factors for that, Karen?
Success, there's both direct and indirect success. I'll start with the indirect. The indirect is the patient or member or provider has a better experience. They are either talking about a positive experience, they were able to get the care they need. If you think about when people use the healthcare system, usually they're somewhat sick and they have zero mental bandwidth to deal with anything. They don't even know the questions to ask because they're not engaged with this every day. It's not like going to Amazon, or it's not like going to your grocery store where you know what to do. They don't even know the questions to ask. So success is you've helped ease some of the troubles, the hardships that someone is in right now, whether mental, financial, or the like. But success is also, we've gotten people to go in for preventative screening. So we worked with Sutter Health, a hospital system, Northern California, and we got 2.1 times as many women to go in for their pap smears in the first 60 days. And that is success because you're truly helping people do the screenings they need. And in the first 60 days, there's something like 5,000 women found out about abnormal pap smears. You don't want an abnormal pap smear, but the point is they now know about it, and they can take care of it.
Take a movement, yeah.
And so that's really a very direct success for us of outcomes versus experience.
Yeah, that's great. You mentioned a couple minutes back, Karen, that you were working with this Medicaid plan and you specifically looking at engagement and the right moment in time to do the health risk assessment. Behavioral economics and Medicaid made me think about health equity and sort of considerations of equity, access. Can you talk a little bit about, I guess, again, where VAL Health kind of integrates considerations of equity and access into the work you do?
It is a great question because humans are humans. We have some of the same biases. However, we know that sometimes, particularly with the Medicaid population, there are certain tools that we don't use. So we don't use exclusivity because that creates red flags for trust. Are you trying to scam me? We also look at the hurdles to engagement, to doing a behavior. So, for example, mammograms. We were working in one of the southern states trying to get more Latino women in for their mammograms. And some of the hurdles there were they're working multiple jobs. They can't commit to a certain date in the future. There's childcare. There's all these hurdles. And so our recommendation was take one of those mammo vans, the mobile ones, bring it to the grocery store where people are, and be able to walk up and do your mammogram without an appointment. So we factored in the different hurdles, which really takes into account a lot of equity or challenges. And then during the pandemic, there was a lot of work we did on increasing vaccination rates, understanding different populations, and you can tap into local experts, local champions that create trust that didn't exist there before. So, for example, if I, my ivory tower, start talking about vaccines, that might not work for someone who is brown, black in the South, in their community, in their church.
Right.
And so we need to go that route.
That's amazing. I saw an example. You've probably seen this as well, not that long ago. I want to say it was in Baltimore, but now I'm also thinking it might have been in Philadelphia. But in terms of men's health engagement, specifically African-American men's health engagement, bringing health service workers into barbershops.
Yes.
Because again, that's where these, where men are congregating and even just being in that environment, being more relaxed and more open and more willing to have maybe a conversation that in your doctor's office, it's like, no, I'm not having that conversation.
It's very true because when you go into your doctor's office, usually people are very defensive. So first of all, who goes in, and then you're defensive. You don't want to leave there with your doctor telling you you're not doing well, and you've got 5 things you need to take care of. And by the way, you need to stop eating, drinking, and you need to start exercising.
Yeah.
Everyone knew that before they walked in, right?
Starting to feel bad about themselves, right? Yeah.
Right. And so we think a lot about, we try not to do regret framing. We try not to do social shaming. We really focus on the positivity
Mm.
because that's what keeps people moving.
And has that been the most effective? I'm assuming the answer is yes, Karen, but in terms of the inertia or resistance to change, is it that sort of approach that has made the most opportunity for success for you?
It's a great question. So we think the main tools we have in our toolkit are choice architecture, framing, and principled incentives. So choice architecture is how do you change the default? How do you eliminate steps? How do you make the right path the easy path, for example? How do you have stairs that are very attractive so people walk those versus go find an elevator? And if we can change a default or the choice architecture, that is hands down the most impactful we can do. When we use strategic framing, it really depends on the situation. Sometimes it's anchoring, sometimes it's social comparison, sometimes it's gain framing. It depends on the type of behavior and the situation we're in. So I wish there was one answer.
Yeah.
And then the third element, which is principled incentives, people often say, well, we're not paying people to do things. And that's often true. However, there is a cost or a no cost. And that cost might be an opportunity cost. It might be an actual cost that needs to be reframed for people, such as, this benefit is included in your program. You don't miss out on using it.
Yeah, take advantage of it for sure.
Yeah.
I've certainly worked on programs, Karen, where there has been a paid incentive, right, to do something. So I've worked on programs where, again, for expectant moms, to pay them to engage in prenatal care.
Yes.
Right. But to also to your point, just paying them to engage doesn't remove some other barriers like childcare, transportation, or just mistrust. If you're paying me to do this, there's something fishy about that, right?
Very much so. And that was one of the concerns in the pandemic when trying to pay people for their vaccine.
Sure. Yeah. Yep.
Because the early adopters got their vaccines. It's the later adopters that were, well, do we need to pay people? And it's the later adopters that tended to be more skeptical. And so why are you paying me?
Yeah.
And so for us, the financial incentives is a last resort.
Yeah.
If it's coming from your employer and wellness incentives, has a slight different spin.
Mm-hmm.
And we've seen a lot of work, particularly in the lower income populations, on paying women, in particular around quitting smoking or stopping smoking when they were pregnant.
Sure.
And so it does work in some situations.
When you think about scaling, Karen, is there, because again, you think of, we'll pay people and that's how we'll scale, right?
Yeah.
But when you think about scaling behaviorally informed interventions, is it a policy thing, Karen, that we have to do? Or I'm curious as to what your thoughts are around that and how we scale.
Great question. So I think scaling, it really depends on the situation, but I'll come back to, is it a policy issue? So I'll come back to the pandemic since we all lived through that.
Yeah.
There's a lot of work we were doing right before the pandemic on increasing telehealth adoption.
Right.
How do you get providers to use it? How do you get patients to use it? And there was a lot of friction in place. There was, how are the providers going to get paid? You've got to download all these apps. There's what can and cannot be done via telehealth. And then the pandemic came and that entire Band-Aid was ripped off. Right? There was all kinds of exceptions. It was paid at parity. People were like, well, if I need to see my doctor, I can use my phone. I don't have to, there were so many exceptions. And so keeping the policy in place that eliminated that friction, it is a good idea. So if there are policies really focused on specific ways to improve the patient member experience or the provider experience and reducing friction, that is where policy can come in.
That's important. I think even more important now, right? As healthcare policies continuing to change very rapidly.
Yes. Yeah.
Absolutely. I would love to talk a little bit about you. So we've talked a lot about VAL Health.
So much easier to talk about VAL Health.
We've talked a lot. Yes, we talked about behaviorally informed incentives and behavioral economics. But this is a conversation that is dedicated to women leaders, and you're a woman CEO in a sort of science and strategy driven space. Has there been instances, Karen, where you've kind of navigated or had to work through leadership or earned influence, just by virtue of your gender?
It is a great question. And the definitive answer is yes. I will say that as I advanced in my career, it is less of an issue. And I think that's for two reasons.
Mm.
One, I think society is getting more equal.
Mhm.
I'm not going to say how old I am, but people can figure that out. And the second would be I've built up a reputation.
Mm.
So I would say the way that I tackled it, particularly in the early years of starting VAL Health, because we are a boutique firm, but our clients are the executives at national firms. And
Right. Sutter, you mentioned that's a huge,
yeah,
huge health system. Yeah.
yeah, they tend to be male and usually white male. And again, that's changing too.
Sure.
So the way that I would tackle this and still do is lead with evidence, lead with stories, factual stories, lead with examples,
Mm.
because then hopefully people are hearing what's coming out of my mouth and
Sure.
recognizing the fact base as opposed to just looking at who I am.
That makes a lot of sense, Karen. I want to go back even further, though, because you mentioned a fairly extensive career in the consulting, managerial consulting space, strategy consulting space. Also, predominantly and historically a male-dominated space too.
Very much so, particularly when I was in Asia, that was quite interesting.
Oh, yeah, that's a good point. Yep.
And it was, I would say we were probably 25% female
Mm.
at the time that I started. And then going to Asia, which was really interesting in that not a lot of women, however, being American had a very different take. It was, it's in the late 90s or early 90s. And so it was very much like, oh, someone from the United States is over here.
Yeah.
So I've learned over the years to play up certain elements of what helps and play down certain elements of what hurts.
Hmm.
And it's become, you don't go in the room and say, well, I'm the only woman in here. You go in and act like I belong here.
You belong. Yeah, you belong at the table, right? Yeah.
You belong at the table and be very humble. But also you have to recognize that you have to promote yourself, which is not something I'm very good at, but it's learning to promote yourself in the evidence-based way really helps.
I love what you just said about that. 'Cause again, two things. One is, we talk to a lot of women on this program who either say, I elbowed my way to my space at the table, or I said, heck with your table, I'm going to create my own table, right? It's kind of one. And I'd love your thoughts around that. And then the second is what you just said about promotion and folks just not feeling comfortable sometimes because of the role that the gender dynamics play on oh, I'm not supposed to promote myself, it's not something I should be doing, right? So you mentioned promotion, so I'm interested in your thoughts there.
One of the things my parents did to me is they did for me is they taught me to run my own race.
Yeah.
And that could be whether you're doing a triathlon or it could be within your career. And so in terms of going outside the ecosystem to create something new, that wasn't really of interest to me.
Yeah.
It was, well, this is what everyone, not that I follow everyone, but this is where the masses are. I'm going to go in. But within that, I will say, if there are other women there, I do tend to lean toward the women.
Yeah.
And we help each other. Because as a group, but that doesn't mean I'm going to go just create something totally different versus work within the existing system.
That's a good point. I really appreciate that. Yeah.
In a way, it's behavioral economics. It's like, how do you make the right path the easy path within the current system?
Right.
To accomplish what you need.
Right. I'm not necessarily going to invent a new system for sure. Right. Yeah, absolutely. There's this intersection that you're sitting at. You're sitting at this intersection of health and innovation and impact, or proposed impact. Again, this is a situation that I think women as emerging leaders can play a very interesting role in. We know that women are predominantly the decision makers in households when it comes to consumption, not just of healthcare, but kind of in general, right? In terms of what comes into the home. As you think about emerging leaders in this space, especially women, and they're thinking about how do I work at these intersections? And I just gave one: health, innovation, and impact. What are some of the things that you kind of either live by, Karen, or what might you recommend to a young woman who's thinking about that?
Follow your passions and don't take no for an answer.
I love that.
In terms of, if you do what you're passionate about, you're going to be confident. You're going to do really well at it. But I would say also recognize that not everything's going to work out. So there are definitely in some situations where I'm going down a path, I'm like, they want a white male and I'm just never going to be that. And so just learned also to I don't say abandon, but rather than fight every battle, pick your battles. And I think that's something in life as well. If you fight every battle, then I wouldn't learn and become a better person.
Right.
Because sometimes I need to look at a battle and be like, oh, that's not the right one for me.
Worth me fighting.
Over here, I can go move quicker or smoother, or I can become a better person there.
Yeah, no, I appreciate that a lot. I think that's really good advice. I think you sometimes forget the pick your battles advice. I know that's advice I give to my Gen Z daughter sometimes. Do you really want to fight that battle? Maybe pick your battle, maybe focus over here a little. When I was a freshman in high school, I remember my English teacher giving us a writing assignment around defining, and sometimes you do this as an obituary, right? But sort of when defining, your success in life, your legacy in life, when you look back, what would success look like for you? I'm fascinated in what your answer to this question is going to be as a behavioral economist. What's the legacy, Karen?
I think the legacy from a career perspective is one, the people that we've developed on the team that are still at the team or have grown on to do wonderful things.
That's really cool.
So that's really important, is how do you help develop people? And the other would be each person individually that we've had an impact on, whether I know about it or not. Each woman that went in for their mammogram, or each woman that stayed more adherent to her breast cancer drugs so that way she could get to her daughter's graduation, or each individual person. That is really important.
Yeah. I think so many of us, when we did that writing assignment, you wrote it and it was materialistic, 14 years old, right? So it was sort of materialistic in its, oh, he had all this success and had all these things. And then, you start to think about actually impact is really what I'm looking to make here, right? I love what you said about looking at the folks that have worked for you and have gone on to do great things, but then also the notion of, if I could just get that one person to do this one thing that's potentially going to have a large impact on their personal health. Gosh, I hope I can get them to do that. Right.
Very much so. That's what gets me out of bed in the morning. That's what gets me pushing harder for messaging or testing, or that's what gets me to fight the battles.
Yeah, I love that. I worked on a product years ago, Karen, where we were using as our tagline that our analytics were helping you to dispel myth and dispel rumor. Because again, our analytics were advanced, and we felt if you followed what our analytics were telling you, the myth and rumor associated with your provision of healthcare was going to be something you could battle, right? I would love, your thoughts on. There's a lot of healthcare myths out there. When you think about myth busting, which was a great TV show, I would love to know, what's the one healthcare myth that VAL Health just loves to bust?
I'll start with the common language. Information alone isn't going to drive healthy behaviors. And the biggest breakthrough in healthcare isn't going to be medical, it's behavioral. We really try and just throw more information at everyone. Here's the facts, but that's not it at all. It's how do you use the behavioral biases to actually get people to change? We've got fabulous medicines, we've got fabulous doctors, and the big complaint is no one does what the doctor tells them to do, and no one takes their medicine. And so it's not more medical, it's behavioral that really needs to happen.
Yeah, I think that's really interesting, because you say there's so much information out there, and it becomes overload, and how do you sift through all of that and make it actionable, right?
Behavioral science really bridges that gap between knowing and doing, because most people know what they need to do. They really just have a hard time doing it.
Yeah, that's very true. Very true. I like that. And I think what you said earlier too about, I don't want to leave the provider's office feeling bad about myself, right? And helping that for sure. Yeah. Earlier, you had mentioned Stephen Levitt's book, Freakonomics, and it's one of my favorites. What's on your reading list right now, Karen? What are you looking at?
I'm embarrassed to say I don't have that many books that I'm reading. I'm reading about how economics can tell the future of the world or something like that.
Oh, that's
I can
cool.
picture it, but I'm not reading any. Behavioral economics to me is more on finding real world examples as opposed to reading books.
Yeah, that's actually good. Actually, I think that's one of the cool things about a book like Freakonomics is they focus more on those real world examples. Part of it, right? Because there's a lot of theory associated with it.
Right. People don't need to necessarily know the theory. What they remember is if a Hershey Kiss is free or Hershey Kiss is a penny, it changes the amount that people will eat, and it's only a penny.
Right.
But when you go from 0 to a cent, there is the zero factor. It's a huge difference.
Yeah. Yeah. And again, behavioral nudges, right? Certainly.
Oh, yeah. Yeah.
The healthcare system, as we mentioned, it's so complex, right? And there's so many facets. You mentioned value-based care a few minutes ago, and it's one thing I was like, oh, you stoked another thought in my brain associated with the risk model and the value-based model. I know there's a lot of things about U.S. healthcare that I would love to be able to kind of snap the finger and change, or wave the wand and change. What would your one, if maybe it's not one, maybe it's multiple, Karen, but what would be your, magic wand moment as it pertained to our healthcare system?
That is a loaded question, but I will try and narrow that down. I would say our healthcare system doesn't fail because we don't care.
Right.
I think it fails. I know it fails because we add a lot of friction.
Mm.
And so I feel like we don't need to overhaul the healthcare system. We could, but what we could do in the nearer term is focus in on the moments where patients are deciding to act. And how can we help them in that moment? So, for example, if I go in, I'm finally ready to seek care, and then I need an MRI, and then there's friction put in place, and I have to wait, and then I actually never go get the MRI. Mm. And so when people are ready to take action, how do we empower them to do that? Right. How do we think about streamlining the experience? How do we think about the framing and the nudges that we can give to them? Mm. And so that is probably not on policy or grand system change, but if collectively we do that.
Hmm. I appreciate that. Earlier, again, we also talked about how do you make changes within the existing system, either maximizing, minimizing, not reinventing necessarily, right? Yeah.
Right. Yeah. We don't need to yell louder. We need to yell smarter.
Right. Absolutely. I worked years ago on a project associated with when you said the yell louder, it made me think of this associated with English as a second language and trying to get interpreter services and whatever you needed to kind of break cultural barriers. And one of the things we were talking about is yelling louder doesn't make the patient understand you
totally
any less or any more, for that matter, right?
So if we think of information, people travel internationally, they just start yelling in English. Right. But if you think about healthcare, you can put calorie labeling. Mm-hmm. And when that was introduced to New York City, people purchased the same number of calories before and after.
Right.
Well, if you go to a Subway sandwich shop and change the order in which items are listed, low calorie items listed first or high calorie items listed first. When low calorie items are listed first, people purchase 25% fewer calories.
Sure, because they stop earlier, exactly. Right, process. Yeah.
So how do we bring that into our healthcare system?
Yeah.
You're not leaving the doctor's office with 9 things to do. You've got 1 thing to do.
Right.
Or, how do we help reduce choice overload to get people to act behaviorally they really want to do it. They just need help doing it.
I have a friend who is a usability expert at doctoral level and loves to spend her time photographing and posting on social media bad examples of usability, right? So it could be signage, it could be a product, it could be, So do you spend your whole day just walking around looking at examples?
Oh, totally. It's so unfun. I'll be at a cocktail party and I'll start talking about these things. It's really kind of funny because you just see, even if you go, I went to a conference, it's like a healthcare, healthy food, wellness, and you go to the lunch and it's like all of this fried food. And then at the end, it has the salad.
Salad. Yeah.
Even if you're going to have the fried food, put the salad first, because then people fill up their plate with the salad.
Right.
But by the time you get to the end, you have no room for it. So I'm always thinking that way.
I love that. Yeah. The smaller plate theory, right? For sure. Yeah.
Exactly. Yes.
Great. Awesome. Karen, I've really enjoyed this conversation. I think we could keep talking for a long time about this. It's fascinating stuff. I understand why you're a hit at cocktail parties. Where can our listeners find more about you, your work, and VAL Health?
LinkedIn, Karen Sussman Horgan.
Perfect.
Through posting, you can see some of our behavioral economics in the wild. And then if you go to VAL Health, VALHEALTH.com, We have a newsletter that comes out every 4 to 6 weeks, and it gives examples of real world behavioral economics of what works and doesn't work. And so that way your listeners can also become so much fun at a cocktail party and talking about these examples.
I think you'll find encouragement and insight and maybe
There we go.
healthcare change makers themselves one day, right?
That would be wonderful.
That would be
And
wonderful.
feel free to reach out to me directly as well. I'm always looking to have conversations with really smart, engaging women.
Oh, perfect. Thank you so much. Karen Sussman Horgan from VAL Health. Thank you for your time today. We really appreciate it, and we look forward to staying in touch.
Thank you, Richard.